Okay. All right. Well, we'll go ahead and get started. So my name is Melissa Wright, and I'll be moderating this session. We have a great panel today. We have Dr. Tammy Smith, we have Dr. Sydney Lee, and then Dr. Tim West. And then I think Dr. J.J. Galli will be joining us here in a minute as well. We'll go ahead and just get started with some introductions. So I'll pass the microphone to Dr. Smith. Just some quick introductions about where you're from, where you work, and what patients you see.
All right, so, wow, this one's way louder than the ones downstairs. Okay, so my name is Tammy Smith. I'm an autoimmune neurologist. I primarily see patients at the VA Medical Center here with all sorts of neurologic disorders, and then I see clinical trial patients here at the University of Utah.
All right, trying to make sure I'm not too far or too close. Welcome, everyone. I'm Jonathan Galli. I'm also one of our autoimmune neurologists between the VA and the University of Utah. And I'll apologize in advance if I run out of the room. I'm also double covering our inpatient service right now. So.
Right, and I'm Sydney Lee. I'm an autoimmune neurology fellow here at the University of Utah. And I see patients with all types of autoimmune neurologic conditions, as well as some multiple sclerosis.
And again, I think you guys met me before, but Tim West, and I work over at Intermountain Health. I used to be an academic. I was at UCSF for a while, and before that I was at the Cleveland Clinic, and now I'm just a clinician. So I don't do a ton of research. We do a little bit, but not as much. I actually funnel a lot of research patients back up to these wonderful people up at the U. And as you probably know, in Utah, select health insurance can't come to the U. So when people switch to select health insurance, they tend to come over to me. So I see all of the neuroimmunological issues. I'm kind of like the lead neuroimmunologist for the whole Intermountain system across the state of Utah, but I also see a lot of MS, which is sort of my main specialty.
Great, thank you for those introductions. So I want this session to be a lot of just discussion and for you guys to be able to ask questions, but I think just to get things started, I'm hoping that the panel can talk a little bit about, I know we went over a little bit about what autoimmune encephalitis and stiff person syndrome, what those disease processes are in the bigger panel, but I am hoping the panel can speak a little bit about the process of getting diagnosed, sort of what the symptoms are, and the diagnostic process for patients with, we'll start off with autoimmune encephalitis and then move on to stiff person syndrome, just while people are trickling in, and then we can kind of talk more and move on to some audience discussion as well.
Yeah, so I can talk a little bit about autoimmune encephalitis. So autoimmune encephalitis is a big group of diseases. There's lots of different types, so I can kind of speak more generally. This is something that can affect anybody of all ages and tends to come on pretty quickly. So over the course of days, weeks, maybe a few months, and people can present with a lot of different types of symptoms. And it can really affect any part of the brain. So, classically, people come in with difficulty with their memory and their thought process. They might have some psychiatric symptoms. They may progress to develop seizures and movement disorders, maybe difficulty regulating their heart rate and their body temperature. So this is something that comes on really fast. Often people will come into the hospital. And when we see somebody coming in like this, we ask a lot of questions. We really want to get a good understanding of the clinical story, to try to get a good understanding of what might be going on. And then patients will undergo a number of different tests to try to add some clues to the puzzle. So that could be an MRI of the brain, lumbar puncture, EEG, blood work. We may also, look for an underlying cancer. And then we really take all those pieces together and try to put that in the context of the clinical picture to make a diagnosis. And of course, antibody testing is very important for that, to really define the subtype of autoimmune encephalitis and guide further workup and treatment going from there. So it can be a long process to come in and get diagnosed. We often try to keep an open mind and do our best to arrive at an answer. And yeah, it can be a long process, and then we try to start acute treatment and then secondary treatment as well if needed. So, yeah.
And then what about stiff person syndrome?
So stiff person syndrome is, it's lumped in with autoimmune encephalitis as an autoimmune condition, but it's oftentimes a very different presentation, and one that can be really tricky clinically to diagnose. And those of you with SPS have probably experienced this, because the symptoms are so atypical for what we typically will see. They don't localize well to one spot of the brain or the spinal cord. Oftentimes it can be a hard diagnosis to get to, one that gets blown off for years. And so typically the way we think about stiff person is classically you get truncal rigidity and spasms. So that's the muscles in the back, the core, shoulders, and quads. That's if you follow the textbook. Sometimes it can be a little bit further out, hands or feet. And then to make things even more confusing, you can also get stiff limb syndrome, which is just one limb. So it can be kind of all over the place how it presents. And really, in order to not miss it, providers have to be kind of willing to entertain the diagnosis altogether, because at first it might, on paper, just sound like it doesn't make sense to anything we've heard of, which some of you may be able to attest to. Diagnostically, back when I was a fellow and we were giving a similar talk, it was a little more hazy how we came to a diagnosis. Our friends from Mayo have put out much better diagnostic kind of guidelines and criteria. And so really, the big thing that we will typically do is blood testing for one of several antibodies, GAD65 and glycine receptor being the two big ones. And we like to look in both the blood or the serum and the spinal fluid. And the reason that is, anybody who's been worked up for me is, especially under these new criteria, the GAD65 antibody is notoriously present in the general population. And so you can have GAD65 in your serum, even at higher levels, maybe not so high that we see with stiff person, but it's just in the general public. And so that can be a little bit tricky to kind of discern on its own whether or not we are worried about it clinically. And so the spinal fluid, kind of my general rule is there should never be GAD65 in the spinal fluid, and we should really never see inflammatory changes in your spinal fluid. And so if I see either or plus the GAD65, that's when I really start to get more concerned. EMG or electromyography, so where they do the little needle, that can be really helpful diagnostically. It's not entirely specific for stiff person, so it more just adds to kind of the overall putting together pieces of the clinical puzzle. And sometimes it's tricky because if you're already on diazepam, it's hard to convince you to come off it because you're going to hurt more to get the EMG. So those are some of the bigger ancillary tests. We usually will do a cancer screen, and then we will do MRIs and other imaging to make sure we're not missing something, because I don't want to misdiagnose, cervical stenosis, so narrowing of the cervical spine around the cord, and start you on IVIG when you really need to go see a neurosurgeon. So that's kind of diagnostically stiff person in a nutshell.
Thank you. And Can you talk for a minute about, we discussed some of the immunotherapies that are used for both stiff person syndrome and autoimmune encephalitis. Can you speak for a minute about some of the other things that we use for treatments in terms of symptomatic support, or just the team that we build around, or other sort of things that we do to support patients or that might be needed for some of the symptoms that patients experience?
Sure. So it depends on what symptoms people are having, what I'm going to consider treating them with, right? But I do think one important thing with all of these diseases is when people present, we often think, let's focus on the immunotherapy. Let's make sure we resolve this inflammatory event and we prevent relapses. And that's often what a lot of neurologists are going to focus on, because you're complex patients, right? And so it's actually really important to know that you should bring other complaints and concerns to your neurologist. So if you're having headaches, spasticity, difficulty with your memory or thinking, things that might be overlooked because we're patting ourselves on the back saying there's been no relapse, or no seizures, some of the big things that neurologists are focused on. So the symptoms can be broad, right? So for stiff person syndrome, the hallmark is this spasticity. So we use a lot of anti-spasticity treatments, but also along with that syndrome, we see a lot of mood disorders. So getting mental health therapy and sometimes medications to help with that as well. And recognizing that those two things can go together and asking about it. So proactively, it'd be nice if your neurologist asks you about every possible thing that could be going wrong. But the reality is you're inside your own body and you're your best advocate. So just don't be afraid to bring up issues that are new or bothersome, and let us know so that we can address them.
Yeah, no, I would just add to that. I mean, one of the weird things that we always do is, the way I describe it to patients is that this medicine's trying to stop the process, but it's not necessarily going to make you feel better. So other medicines are there to make you feel better. One stops the attack, the other one helps you feel better. And so that's where sometimes just showing up with a list of these are my problems. We really try hard to ask the questions, but yeah, I mean, to Tammy's point, we're not inside your body. You guys know your body, you know what you're struggling with. And also this is sometimes where having a loved one around helps. Like, hey, remember, ask that thing that I told you to ask about. That actually is a big deal. And maybe if they're going off to clinic and you can't make it, like, hey, do you have your list? Or you make sure to ask that. Because I have patients who'll say, look, I don't want to ask this, but my wife said I have to ask this question. And that actually ends up being really what they're struggling with. So as loved ones, you can definitely advocate for the person who's got the condition in this way.
Yeah, and just another thing to add to that, we talk about medications, treating the underlying process and then symptomatic medications, but just remembering as well that there are other modalities of treatment. So we work very closely with physical therapy, occupational therapy, and whatever other supports we think somebody might need. So yeah, don't be afraid to ask if you think about something or want to try something. Yeah.
Thank you. I want to be able to give you all an opportunity to ask questions to our great panel. So does anybody have any questions? Go ahead.
I do. I have a question.
Oh, this doesn't reach actually.
With the
Okay.
microphone? I can try and project. But I do love a microphone. My question is for Dr. Jonathan Galli. I was curious as to whether stiff person syndrome and autoimmune encephalitis are overlapping diseases. I am positive for 14 antibodies, including GAD65 and glycine receptor. I just thought it was interesting that you mentioned them when you were talking about stiff person syndrome, because my diagnosis is broad spectrum autoimmune encephalitis.
If we don't break the microphone by the end, it'll be a miracle. No, you're good. That's a great question, and thank you for it. And so the the simple short answer is yes, you can have overlap of both. The way I typically phrase it is, and to make it complicated, is you can have GAD65 and glycine. We looked at this further back than I'd like to admit when I was a fellow, but we definitely see overlap in a lot of our patients. Clinically, I do like to try to define it as if somebody has just stiff person syndrome, GAD65, then when I'm saying, you know, so-and-so is presenting for follow-up of blank, it'll be stiff person syndrome. I do have a handful of patients with GAD65 plus or minus glycine that are more broad. And so let me back up just a minute. So GAD65 has been linked with stiff person syndrome, with autoimmune encephalitis, refractory epilepsy, what else? Oh, cerebellar degeneration. So a lot of various different things. And so if I have somebody that has kind of stiff person phenotype plus cerebellar atrophy on their imaging, then I'll usually call them GAD65 mediated neurological disease characterized by . It's more of a semantics argument when you're doing that, but what I'm getting at is you definitely can have overlap of all of them. Now, the question, you know, if you want to get into the weeds is GAD65 causing all of these, or is it a kind of, you know, secondary antibody? You know, if you join in our division meeting, sometimes we'll argue about it, but we don't have the answer to that yet. But we definitely can see overlap, excuse me, across the board.
What other questions? Go ahead. I don't know if it will reach. Okay. Yes, yep.
So, same person, I'm sorry, can't see you very well, but you said earlier that you look at the level of GAD65, and if it's at a certain level, then you realize it's stiff person, otherwise you look at you tell more by the spinal fluid. What level?
So the question was referencing what Dr. Galli mentioned earlier about the level of GAD65, the antibody, and if it's above a certain level, then providing more confidence about the diagnosis of stiff person syndrome, and if not, looking at the spinal fluid.
I'm actually going to punt this to Dr. Smith because she's our lab guru and can tell you more the most accurate piece of this.
So yeah, these are great questions that are still debated in the field, right? So getting a test result reported as positive or negative and with a number in your medical record, there's a lot of nuance behind that. So the way the testing is done is different at different labs. So if you have a doctor who sends their testing to one laboratory, there's about 4 big national clinical reference laboratories, maybe 5, depending on how you count. So depending on where they send it to, they're testing by potentially different methodologies. And so to tell you an absolute number, like this is the number that counts, is impossible, to be perfectly honest. And none of these lab results mean anything outside of the clinical history in an exam. So if I just tested every single person who drove down I-15 today for antibodies, regardless of what's going on in their body, I'm going to get some people throwing positive antibodies. That's the nature of the testing. But they might not have any clinical symptoms at all. And then there are also, as we talked about seronegative people this morning, people who have profoundly impactful neurologic symptoms who are seronegative for everything we know to test for right now at the current state of the art. And so I think I'm passionate about laboratory testing and educating people about it, but probably the most important thing I can say is just don't treat a black and white number or a red exclamation point in your medical record as the truth or the answer, or have it be negative and then say, gosh, now nobody knows what's going on with me, okay? Your clinical history, super important. Your neurologic exam, those two things together, the most important. The lab testing, again, which I'm passionate about improving the quality of and helping people understand how to interpret it better, is auxiliary, as is any of the imaging studies we do. Sorry, that's not the number you wanted me to give you.
Just when he said there's a certain level, I thought, I mean, I know what his levels are, I just was.
It depends on what lab you send it to, and it depends on whether it's from serum or CSF. So it always depends. That's our hand-waving answer, yeah.
Other questions? Okay, good.
So, to tag to her, 23 years ago when I was diagnosed, my little pamphlet, this is what we had, said anything over 0.1. But we now know that that's not exactly true. So it has changed. I'm also a type 1 diabetic, which will produce, again, 65 results.
So the comment was that back when she was diagnosed many years ago, there was a pamphlet that she got that said the level was 0.1, and that things have changed since then, and that she's also a type 1 diabetic, which can also result in a positive GAD65 antibody. So just illustrating the point that things change all the time and that our understanding of this changes all the time. What else? Go ahead.
So we know that many of these conditions may show up as, quote, seronegative. Part of that may be that we just don't have a test yet. We don't know what's causing the seronegative patient's symptoms. For example, NMOSD is this way. There's also seronegative AE. I think there's seronegative SPS, is that correct? Yes, okay. So in our experience, we find patients that are maybe in suburbs or rural settings. They don't have access to a top academic medical center, a community hospital perhaps, or a clinic neurologist. They get their tests sent out, but as Tammy knows quite well, like there's tests and there's tests. There's various different types of tests, centers that are reference labs versus not. So what advice would you give seronegative patients? Should they know where they got their test done, and if so, how to follow up, how to get a second opinion? Maybe you could speak to that both for AE and SPS.
So for these autoimmune diseases we're talking about, we often use antibodies that we test in the blood to help say for sure, like you have an antibody against GAD65 or amphiphysin, right? So whatever those antibodies are. If you're seronegative, we've tested for all of the antibodies we know about, and everything came back negative. Oh, I'm sorry, SERO. SERO for like serum. Yeah, thank you for that question. That's really important that people do ask that stuff. I apologize. I think a lot of our seronegative patients are used to using that term and being like throwing their arms up and saying, I'm seronegative. So we forget that not everybody knows. Yeah, thank you. Yeah, so I would say that anytime you get any testing done, you're on a diagnostic journey, and it's really helpful to keep your own records. And I find a lot of patients come to my clinic and they say, oh, it's all in the computer. Like, you know what meds I'm taking, you know what I was tested for. But the reality is our computer systems don't talk very well together. So I think one of the better things you can do as you start on a journey with a rare disease is keep your own records and write down exactly what was tested, exactly where it was tested, and the date, because every year we find new antibodies. And so if you get tested for a panel of antibodies 5 years ago, the panel with pretty much the same name today has new antibodies in it. And so if you write down the date of the testing, where it was done, and ideally, I mean, I like a good printed folder because I'm really analog, not digital, okay? But if you get imaging done, you all know what a pain in the neck it is to sit in a scanner for however long, and you get a cramp, and then your nose starts itching. And then you go see another doctor at another healthcare system, and they say, I don't have access to that imaging. So like anytime you get imaging done, get copies of it. Put it in that magic folder. I think that's really an important part of being an advocate for yourself or your family members, is keeping those records yourself and not counting on some computer or some doctor to have all of that together for you. Does that answer it, Michael? Okay.
All right, I think one last question, and then we'll be ready to move on to the next session.
Question.
Okay.
In either AE or SPS, is there certain ethnic groups that are like more prone to either of those?
So both AE and SPS are actually a bunch of different diseases, is the short answer. So within AE, for example, LGI1 encephalitis is a subtype of AE, and people with a specific sort of genetic background are almost always have this. It's not necessarily ethnic, it's sort of this HLA marker. It's complicated and has to do with the immune system. So there are certain ethnicities that are going to be more or less effective, but again, we're talking about a large number of distinct diseases, and each of them is individually rare. So we don't have good data to say, you know, I looked at 100,000 people with this condition, and now here's the ethnic breakdown. We don't have numbers anywhere close to that big for any discrete syndrome. Yeah, good question.
All right, I think we'll go ahead and move on, and I'll turn it over to Meg Poe for moderating. And thank you to Dr. West, Dr. Lee, Dr. Galli, and Dr. Smith.